So today we are discussing recurrent pregnancy loss. So sorry for all the trouble the internet is causing. Defining miscarriage, it is defined as a loss of clinical pregnancy before 20 weeks of gestational age and 18 weeks after fertilization. Or if the gestational age is unknown, the loss of an embryo of less than 400 grams. RCOG and Australia define recurrent pregnancy loss as 3 consecutive pregnancy losses, including the non-visualized, even if it is a chemical pregnancy. Then they will consider it as recurrent pregnancy loss. Whereas ASRM says that there should be 2 or more clinical pregnancy losses, and these should be documented by ultrasound or histopathological examination, but not necessarily consecutive. The prevalence is from 2 to 5% of the couples suffer from recurrent pregnancy loss, whereas we see that about 15 to 25% of the pregnancy they suffer from sporadic miscarriages. The risk of miscarriage, we know that increases with the age. If the woman is less than 35 years of age, the risk of miscarriage is around 9 to 12%, and if it is she's more than 40 years of age, it goes as high as 50%. So the causes of recurrent miscarriage could be an anatomic cause, that is the uterine factors, or antiphospholipid syndrome. They could be endocrine factors like polycystic ovarian disease, hypothyroidism, hyperprolactinemia, luteal phase defects, and uncontrolled diabetes. Genetic factors have also been implicated as a cause of recurrent miscarriage, and it is one of the important causes. There are two etiologies which are considered controversial. One is inherited thrombophilia, and one is chronic endometritis. It is debatable whether these conditions are a cause of recurrent miscarriage or not. Then we should not overlook the psychological and the environmental factors, and most of the times we investigate the patient and we find that the recurrent miscarriage is unexplained. We cannot find any cause for that. So considering the uterine factors, the anatomical defects, they could be acquired or congenital. Among the acquired abnormalities, the causes could be intrauterine adhesions or myomas or endometrial polyps. How does intrauterine adhesions occur? They occur whenever endometrial basal layer is destroyed. And the severity of adhesions will increase with the number of curettage or repeated cesarean sections. Anything which damages the endometrial basal layer can lead to intrauterine adhesions. Similarly, submucous myomas are found in 4.5% of women with recurrent miscarriages, and they should be surgically removed. Similarly, polyps are there in 2 to 3% of the women for which we recommend hysteroscopic polypectomy. Considering the congenital abnormalities, there is a whole spectrum of congenital abnormalities, starting from septate uterus to bicornuate, or it could be a unicornuate uterus. There could be complete failure of fusion of Müllerian ducts, and that can lead to didelphys uterus, or there could be an arcuate. So these are different congenital uterine abnormalities, which I was talking about. Now, septate uterus is the most common type, and it is associated with the chance of spontaneous miscarriage. And there is some evidence, although the evidence is not that robust, that metroplasty, that is the surgical removal of the septa through hysteroscope, can lead to a successful pregnancy in women with a history of pregnancy loss. Now, chronic endometritis is debatable. Chronic endometritis is chronic inflammation of the endometrial lining, and it has been seen that there is increased prevalence of chronic endometritis in women with RPL. It could be as high as 10% to 27%, Endometrial receptivity is impaired by stromal infiltration of plasma cells. And the gold standard for identification of plasma cells is using immunohistochemistry stains for Syndican-1. So this is a controversial thing, and several international societies do not recommend screening for chronic endometritis in their recommendation due to lack of conclusive evidence. Now, considering the antiphospholipid syndrome, which is a very important cause of this condition, antiphospholipid syndrome is characterized by presence of antiphospholipid antibodies, and they has been long associated with recurrent pregnancy loss. The clinical criteria to confirm the diagnosis of APS is pregnancy morbidity, one, and the other is vascular thrombosis. And the prevalence in general population is 5 to 20% of the patients with RPL have this condition. And APL antibodies, they are associated with other obstetric complications also, like preeclampsia, IUGR, and prematurity. Now, the international consensus on classification criteria for APS are at least one clinical and one laboratory criteria must be present for definite APS. The clinical criteria include either there should be a vascular history of vascular thrombosis, that is one or more clinical episodes of arterial venous or small vessel thrombosis in any tissue or organ. And the thrombosis is confirmed through Doppler studies or histopathology, with the exception of superficial venous thrombosis. Or there should be an obstetric morbidity. And what is that? One or more unexplained demise of morphologically normal fetus at or beyond 10 weeks of gestation. With normal fetal morphology, there shouldn't be any congenital anomaly that would have been accounted for the pregnancy loss. So the fetus should be normal and it should be unexplained demise beyond 10 weeks of gestation, as documented by ultrasound or direct examination. Or one or more premature births of morphologically normal neonate before 34 weeks of gestation, either because of eclampsia or severe preeclampsia or placental insufficiency. Or there should be 3 or more unexplained consecutive miscarriages of less than 10 weeks of gestation. And the known factors associated with recurrent miscarriage should be ruled out, like parental, genetic, anatomic, and endocrinological factors. The laboratory criteria is either one of these antibodies should be checked at least 12 weeks apart by a standard ELISA assay, and the antibodies are anti-cardiolipin and IgG-IgM or anti-beta-2 glycoprotein 1 or lipase anticoagulants. So these should be checked. These should be positive at least on 2 or more occasions, at least 12 weeks apart. Not just one reading is not enough for diagnosis of antiphospholipids. So the mechanism of action is an impaired, these antibodies, they cause an impaired trophoblastic invasion. They also induce syncytial trophoblast apoptosis, and they cause abnormal formation of a spiral artery in the placenta. That's why it leads to placental insufficiency, or it causes misproportion because of the impaired placentation or impaired trophoblastic invasion. So the therapeutic approaches, we all know that it is commonly we give these things, that is low dose aspirin or heparin, unfractioned heparin. We are no longer using unfractioned heparin these days. We are using low molecular weight heparin these days. Then the debatable therapeutic approaches are corticosteroids and intravenous immunoglobulins, which usually they are not used, or combination of and the standard treatment, you know that it is low dose aspirin. So if we are giving unfractioned heparin, it should be started with a positive pregnancy test. Even if you are giving low molecular heparin, low molecular weight heparin, you should be started with a positive pregnancy test as soon as the pregnancy test is positive. And it is given at a dose of 5,000 to 7,500 international units twice daily, and it is continued until delivery. And again, you give a break and then resume postpartum for 4 to 6 weeks. Okay? But it could be associated with thrombocytopenia and osteopenia. For that, you have to get a baseline platelet count, partial thromboplastin time, and you should check it repeatedly during pregnancy with a daily dose of calcium, about 1,200 milligram, and vitamin D at a dose of 800 to 1,000 international. Now, aspirin 75 or 81 milligram daily should be initiated before conception, and it should be discontinued 4 weeks before the expected date. And it should be resumed for postpartum fertility. Because these patients will have tendency to make clots and to save from long-term, save these women from long-term morbidity. You should encourage them to take low-dose aspirin daily. And most of the studies have confirmed that the combined treatment of aspirin and heparin increases the live birth rate compared to aspirin alone or low molecular weight heparin alone. Now, hyperprolactinemia, it is associated with subfertility and miscarriage by altering. It alters the hypothalamic pituitary ovarian axis, thus leads to impaired folliculogenesis and anovulation. And it is given in a dose of bromocriptine it is given as bromocriptine 2.55 milligram per day until 9 weeks of gestation. You should continue it during the pregnancy as well. Now, hypothyroidism, thyroid diseases we are seeing a very increasing incidence of thyroid diseases these days. And it has been seen that hypothyroidism can definitely lead to recurrent pregnancy losses, but the presence of subclinical hypothyroidism and its treatment is still debatable, that whether the patients presenting with subclinical hypothyroidism and recurrent pregnancy loss should be treated with thyroxine or not. This is still debatable. Now, again, a very common condition which can lead to recurrent pregnancy loss is polycystic ovarian disease, and it has been seen that many mechanisms can lead to miscarriage in this scenario, because polycystic ovarian disease has been associated with insulin resistance and hyperinsulinemia, hyperandrogenemia, and increased plasminogen activator inhibitor 1 activity. The treatment, we all know that is metformin and myoinositol or dichloroinositol. Uncontrolled diabetes, we all know that it is a very common cause of recurring pregnancy losses and bad obstetric outcome. It increases the risk of miscarriage, whereas an adequate preconception, if we control diabetes preconceptually, then we can achieve a pregnancy as good as a normal pregnancy, we know that. Then luteal phase deficiency. Luteal phase deficiency is deficiency of endogenous progesterone or its action on the endometrium in luteal phase, thus impairing the normal implantation. The treatment which is usually used is progesterone supplements and HCG. Now, the genetic factors, majority of the early pregnancy losses, 50 to 60%, are consequence of chromosomal abnormality. There could be chromosomal abnormality which can be of parental origin, or it can arise de novo in the embryo from parents with normal chromosomes. So the most common parental abnormality are balanced translocations. With balanced translocations, phenotypically the person is normal, but they may transmit abnormal chromosomes to their fetus, and it is found in 2 to 4% cases of patients with recurrent pregnancy loss, as compared to 0.7% in general population. So these patients are, as I have told, that they are usually phenotypically absolutely normal, they are asymptomatic. But the karyotype of the products of conception can show either a normal or a balanced or unbalanced translocations. And pregnancies with unbalanced translocations usually end in miscarriage. which is Allah Ta'ala ki meherbani ke it is a natural selection mechanism, or because the fetus would be abnormal if it grows, or it can lead to stillbirths, or if they are unluckily born live, then they will deliver with major congenital defects. So, embryonic aneuploidy usually it is found in those patients who miscarry before 10 weeks of gestation. So 90% of the chromosomally abnormal fetuses are spontaneously born. For that, how to address the genetic problem for this? Now we have pre-implantation genetic testing through IVF. It is available now, and it is due to balanced transportations. What PGT involves is controlled ovarian hyperstimulation. We stimulate the ovaries, we retrieve the oocytes, then we do the IVF. Then with IVF, we get the embryos, we do the embryo biopsy, and then we send the biopsy for DNA testing. And if the embryo is euploid, we will put back that embryo in the uterine cavity, place the embryo in the uterine cavity, do the embryo transfer. If the embryo is ineuploid, then we will defer embryo transfer in this patient. So we can select euploid embryos and we can address this problem with that. So, workup is not recommended to evaluate patient following one miscarriage. With patient presenting with a single miscarriage, ACOG says that we don't need to investigate them. But if the woman has two consecutive losses, or especially in women if she is more than 35 years of age, we have to address these problems. And how we do it? We take a detailed obstetrical history, a gynecological history, we take a family history of miscarriage, and we ask for, we go for a blood work, which includes CBC, fasting serum glucose, including A1C, prolactin levels, serum TSH, and antiphospholipid antibodies, which are reverse anticoagulant, anticardiolipin, and anti-beta-2 glycan 1 antibodies. Routine screening of thyroid antibodies, routine screening for inherited thrombophilias is not recommended unless abnormal findings suggest that these diseases could be present. But we see that most of the physicians, they would recommend thyroid antibodies, they would screen for inherited thrombophilias, which is actually not recommended by standard guidelines. Now, regarding the imaging, we should go for imaging to rule out anatomical problems. The imaging modalities which we have is 3D transvaginal scan, we have sonohysterography or stereosalpingography, or we can go for hysteroscopy. And even if some case is confusing, we can go for an MRI. Genetic analysis is also not routinely done. It is not a first-line investigation. And when we rule out everything else, then we can go for, and we don't find any growth, then we can ask for order a karyotype or genetic evaluation of the products of conception. Now, there is a huge number of patients whose cause of with the recurrent pregnancy loss, where the cause cannot be ascertained, and even a comprehensive workup will not identify any problem. So it is considered if the complete genetic, anatomic, endocrine, and immune evaluation was performed and everything returned as normal. Couples with unexplained recurrent pregnancy loss should be informed that chances for future successful pregnancy could be as high as 50 to 70%. This is very reassuring. But reassure your patients that still after 3 losses, you still have a chance of getting a normal, healthy pregnancy. And about 50 to 70% of the cases. And it depends mostly on the maternal age and number of previous losses. Now, there is some interleukin genes have been linked to be associated with unexplained recurrent pregnancy loss, like interleukin 1B, interleukin 6, 10, and interleukin 18. A successful pregnancy, that always depends on immune balance and interleukins secreted by immune cells. they have a very important role to maintain a balance at different stages of immune dysregulation and unexplained pregnancy losses has been proposed as potential etiology in the unexplained ones. And here, people do give aspirin or low molecular heparin, but most of the well-designed random controlled trials have failed to show any improvement in live birth rate with these therapies. So they should not be given empirically. Now, we should not ignore the male factor in recurrent pregnancy loss, and these days more and more studies are coming up which indicate that even male factor could be a cause of recurrent pregnancy loss. And standard semen parameters, which the standard semen analysis which we do, they do not seem to be associated with risk of pregnancy loss. However, in vitro and in vivo studies have now shown that an elevated sperm DNA fragmentation rate negatively affects fertility and it could be a cause of miscarriage. But still, it is not recommended as a part for recurrent pregnancy loss. And this test is even not widely available anywhere in Pakistan. Now, progesterone supplementation for recurrent pregnancy loss, some people would empirically give progesterone support for unexplained losses. And actually, Cochrane database in 2013, it has shown that they did a meta-analysis on 2,158 women and from 14 trials, and they found that progesterone supplementation, it was ineffective for preventing sporadic miscarriages. But the data from these 4 trials in women with 3 or more consecutive miscarriages showed that progesterone significantly reduced miscarriage rates compared to placebo or no treatment. So there is another meta-analysis that was conducted in 2015, and it was a meta-analysis of 10 randomized control trials and included more than 1,500 women. And they also found significantly lower risk of recurrent miscarriage and a higher chance of live birth following supplementation with progesterone. So you can give progesterone to these patients even if you don't find any cause for the pregnancy losses. We do pre-implantation genetic screening for recurrent pregnancy loss. We can look at the genetic factors. Up till now, I was talking about the chromosomal karyotypic abnormalities only. If you want to look for the genetic factors, there are several molecular techniques such as FISH, CGH, array CGH, comparative genomic hybridization, single nucleotide polymorphism array, quantitative or real-time polymerase chain reaction, and next generation sequencing. And we do a top ectoderm biopsy at blastocyst stage, and we can check that embryo that whether there is any karyotypic or genetic abnormality in that embryo. And this is a very efficient, and for that you have to have a very efficient vitrification program. So this is just a summary of all the etiological factors and the tests and the treatment options. I will not go into the detail because I've already described them at depth in my presentation. So the conclusion is that the recurrent pregnancy loss is an important reproductive health issue, and many etiologies have been identified. Successful therapeutic routines are also available. You need to thoroughly investigate your patients, especially those with 2 consecutive losses. And we should basically look for the uterine abnormalities through imaging, antiphospholipid syndrome, endocrine diseases, and the genetic factors. Lifestyle modification is very important. Psychological support is also very important. And even after thoroughly investigating, as I said, almost half of the cases will remain unexplained, for which various treatments and various investigations are evolving rapidly. So regardless of a cause, once again, for a follow-up with important psychological support, once again, it is very, very important because your empathetic attitude will help your patients to achieve a successful life. Thank you so much for patience.